in order to decide what treatment options are best for a particular patient, we have a multidisciplinary team meeting at the time of diagnosis and throughout the course of a patient's story. And we have guidelines which will suggest which treatment option may be best, but sometimes there's no one size fits all. Neuroendocrine tumours, out of other tumours that I'm involved in the gastrointestinal tract, are probably one of the more complex. And although we have clear guidelines on some of the initial treatments, there are even experts may differ on what treatment they think is the best. We have to use evidence-based medicine, and we have clinical trials that have been published in various treatments in neuroendocrine tumours that suggest to us what treatments are best at a particular time in a patient's journey. Newer treatments, novel treatments, yes, they have newer treatments are available, but in terms of the treatments that have been available in the last 5 years or so, such as sunitinib, everolimus, they had to go through rigorous processes from development, phase 1, phase 2, phase 3 trials, and in proven benefit in clinical trials. It was only until then that the medical world felt that this is a treatment that is appropriate in certain patients with neuroendocrine tumours. I have to reiterate that there's a heterogeneity in cases, which means that patients have different neuroendocrine tumours, and within someone with one mid-gut or small bowel neuroendocrine tumour may be different from another one depending on the volume of disease in the liver, how much disease there is, and so that there are all sorts of factors which affect treatment options. Going back to the novel treatments, it may not necessarily mean that if you hear about one particular treatment that someone else is on, that it is best for you. You may already be on the best treatment as deemed by your physician, and sometimes there's no right or wrong answer, and there's choice of one or two, in which case it is probably best if those options are discussed with the patient in order to come up with a mutual decision on further management.
Obviously, neuroendocrine tumours are often very indolent and slow-growing tumours, and often because a lot of treatments can have side effects, a very useful strategy may be just to watch and wait initially, particularly if the patient hasn't got very many symptoms, and just get a sense of how the disease is evolving. Very often we may do a scan after a few months and find that there's been very little change over that time in the disease, and often we can then just keep a close eye on people and not give them any toxic treatment that they have to put up with side effects from. The other important thing at the initial kind of period of assessment is to really get the most information you can about the tumour, the nature of its biology. Often patients will come having just had initial investigations like a CT scan, but won't necessarily have had a biopsy. They may not have had functional imaging with ultra-tight scans and so forth. And these things can take some time to arrange, but often we can afford to spend the time to get the results of these tests before deciding on the best treatment for that patient. So often, although patients are keen to start treatment very promptly, that may not be actually the best strategy, and it's often better to make sure that we've got all the relevant information and then decide together what the best approach is. So often when the tumour is first detected, it may show a very indolent character, We look at the way the cancer cells are proliferating in the biopsy, and often that's very slow initially, but the tumours can change their biology and start to become more proliferative and more aggressive in their behaviour. So it can be useful to take a further biopsy to see if those changes are apparent in the tumour cells, and that can certainly lead to a change in our strategy in terms of therapy or the aggressiveness of treatment. The sequence of treatments does vary according to the particular clinical scenario. So obviously the original site of the tumour is very important. We treat pancreatic neuroendocrine tumours very differently from, for instance, small bowel neuroendocrine tumours. So that's really the first kind of step to assess exactly what the patient's tumour characteristics are, how aggressive it's behaving, if it's growing more rapidly or more slowly. For patients with small bowel tumours, for instance, with disease spread that appears to be very indolent in its behaviour, I would often initially just monitor the patient without any treatment if they don't have symptoms. Obviously, if they do have symptoms to suggest a kind of carcinoid syndrome, then we would normally start people on somatostatin analog therapy initially. And certainly if there is a sign of tumour growth, we would often again use somatostatin analog therapy as a first line as an anti-proliferative treatment as well. If the tumour starts progressing some time after that has been commenced, we often then move on either to a higher dose somatostatin analog, particularly if symptoms are breaking through, or sometimes consider additional therapies such as radiopeptide therapy. Nowadays, in the UK, we're somewhat limited in terms of the treatment choices in terms of additional options. We often explore the possibilities of loco-regional therapy, particular for metastatic disease in the liver. So we often try and remove tumours from the liver either surgically or using ablative techniques like radiofrequency ablation, and consider embolization of liver tumours as well sometimes. So the strategy really again depends a little bit on the distribution of the disease, what part of the body it's affecting, whether it's just spread to the liver or whether it's also spread to the bones. So it's quite a complex treatment algorithm depending on the particular factors that are at play in that particular patient. So certainly I think the message is that treatment is bespoke to the patient rather than there being a kind of standard approach across all patients.
Having moved from England to Wales recently, the health systems are different. I can't answer about Scotland or Northern Ireland, but similar themes occur where certain treatments may not be readily accessible within Wales, but there are mechanisms for those to be accessed outside of Wales in England. So, for example, peptide radio-targeted therapy, or PRRT, is available in England and is available for our patients in Wales through a mechanism which has to be discussed through our multidisciplinary team meeting. But once that decision is made, patients end up accessing that treatment, and certainly accessing scans such as gallium PET scans in Wales, if it's appropriate for that particular patient to have a gallium-68 PET scan, although currently we do not have that in Wales, although in the next year we'll hopefully be developing that. It is available and accessible to those patients outside in England in a few referral centres. Things are changing and constantly changing in the NHS, and funding if the ways things are funded, treatments are funding, services are funded in throughout the United Kingdom have changed over the last decade or so. So it can be frustrating, but the hope is there are mechanisms to access the best treatments available for our patients.
I think it's important that the patient understands that you are able to support them with any decision. Coming to my hospital, our hospital, for an opinion and for care doesn't have to result in treatment that you don't consent to. It's important that they have all of the information, and it's good information, and they take it away and are followed up. But if a patient decides, and they've got informed consent and they're making an informed decision, then we should respect that and arrange follow-up as required.
But I think with all surveillance programs, the key is the reason we do surveillance is so that we can pick up things changing early as possible. But no surveillance program is perfect, and things can change from one patient to the next, even with the same type of neuroendocrine tumour in the same grade. So the key message is that if patients are experiencing any symptoms or concern, then they should get in contact with us. They shouldn't just have to wait for that next 6-monthly appointment. We're certainly of the opinion that if you have a pancreatic neuroendocrine tumour, even if it's of low grade and it's resectable, it's removable by surgery and safely done, and we don't think you're going to experience too many of the complications afterwards, then we should remove it. Because even though they're low grade, these tumours, and although the outlook is generally very good, again, it's unpredictable as to when things may change, and therefore either having patients on an active surveillance program or putting them on medication like somatostatin analogues, we think is certainly the best practice. And there's been a lot of talk here today at ENETS about various protocols and where treatment should come in, and certainly the previous studies that have taken place, the big Clarinet study demonstrated that there is benefit of patients being put on somatostatin analogues in terms of improving overall survival, and that quite statistically significant reasons to carry on doing it.
Neuroendocrine tumours of the lung are becoming more prevalent. We're seeing a lot more than we used to. There are 3 main types. There's the so-called typical or classical bronchial carcinoid. Then there's the atypical, which is really the intermediate grade type. And then finally, there is the high grade or high risk G3 neuroendocrine carcinoma. Most of the patients who have a classical or typical carcinoid with no bad risk features, in other words, if it's completely excised and there are no nodes and there's no signs that the blood vessels have been infiltrated by tumor, have an excellent prognosis and just need monitoring and surveillance over a number of years. Personally, I follow patients up for 10 years. There are some who advocate it should be lifelong. How that's done will vary from centre to centre, but in most cases it will consist of some form of annual scan, either with a CT scan or an Octria scan, or if they're available, you may get a PET scan using one of the gallium isotopes. Personally, I also do blood for the gut hormones, at least annually and probably 6 monthly in the first 5 years. For the intermediate grade, the atypical, they have a slightly higher incidence of recurrence of the tumor coming back, and so they may need a little more intense surveillance. It will still be with blood tests and imaging.
Any of the surveillance programs are very much tailored to the patient, and that really does depend on the stage of the tumor, the grade of the tumour, the size of the tumour. So all of those things influence. Some very small appendiceal nets don't need any surveillance at all, and certainly some of the T4 tumours, T3 tumours that have been completely resected at a right with a right hemicolectomy, again, don't need much surveillance. Other appendiceal nets that will need some surveillance, and at the Royal Free, our programme, as I said, we tend to tailor it for patients, and it will be based on ENET's guidelines, but it will usually be a yearly ultrasound scan with blood tests, including chromogranin and a chest X-ray, and we'll usually continue that for 5 years and then review. But it very much does depend on the stage of the tumour at presentation.